Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckville and I will be serving as your program facilitator and will present your questions to our panel of experts. Well, up to 75% of women will develop uterine fibroids during their lifetime. Uterine fibroids are non-cancerous growths that can develop from the muscle tissue of the uterus. Jefferson Health's multidisciplinary team specializes in the diagnosis and treatment of uterine fibroids, from medications to minimally invasive surgery. Jefferson takes a whole person approach to assess the impact of the treatment plan on your future and overall health based on your unique clinical situation and personal goals and lifestyle. Well, thank you for submitting your questions in advance of tonight, and the questions that you will hear me asking the providers are all submitted right from when you registered for this webinar. If you have any questions throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you should see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during tonight's virtual event. And due to hospital, university guidelines and privacy, we are unable to comment on specific cases. Likewise, if you are experiencing any symptoms that may require immediate medical attention, please consult a medical professional. And with that, I will go ahead and introduce our experts for the evening, starting with Dr. Patricia Davis with obstetrics and gynecology, Dr. Karen Gonzalez, interventional radiology, Dr. Kate Stampler, obstetrics and gynecology, and Dr. Patrick Teefy, obstetrics and gynecology. Well, again, thank you so much for joining us tonight. I'll give each of you a minute or two to say hello, give some background about yourself. So with that, Dr. Davis, we'll go ahead and start with you. Hello, how are you doing tonight?
I'm doing great. Good evening. My name is Dr. Patricia Davis. I am a generalist in OBGYN at Jefferson Abington Health and Jefferson Northeast. And I provide comprehensive healthcare to women in the field of OBGYN. And I have a specific interest and spend a good amount of my time specifically taking care of women affected by GYN issues who need surgical interventions. So welcome, everyone.
Yes, thank you. All right, Dr. Gonzalez, we'll turn to you. How are you doing this evening?
Oh, good, thank you. And thank you so much for inviting me here tonight. Again, my name is Karen Gonzalez. I'm a professor of radiology and co-director of the Interventional Radiology Division here at Jefferson. I'm also the co-founder of the Jefferson Fibroids Center that was established about 20 years ago with the goal of providing patients with a multidisciplinary approach to treating fibroids. And this is where I get to work very closely with Dr. Teefy. I first became interested in uterine fibroids and treating uterine fibroids when I was doing my fellowship at Jefferson many years ago, when I had the opportunity to assist in the first uterine artery embolization procedure back in 1999. So I'm showing my age. But so I just thank you for everybody. And I'm glad to be here with these wonderful physicians.
Well, we're excited to have you. All right, Dr. Stampler,
Hi.
How are you?
Good, how are you?
Doing well.
Thanks. Good evening, everyone. My name is Kate Stampler. I am a minimally invasive gynecologic surgery specialist. I run our division at our Einstein Philadelphia Jefferson campus. I have been in Philadelphia for the duration of my medical career and have been at our Einstein Jefferson location for now entering my 7th year. It goes by very quickly. From a career standpoint in my day-to-day job, if I'm not in the operating room, I spend a lot of my time and focus in medical education and simulation, as well as surgical quality and equity for our patients. But I'm really happy to be here tonight to answer these common patient questions that we get a lot in the office as well, submitted by you, and then hopefully can give you guys a little extra clarity on these hot topics and inspire the audience members to ask their physicians the same things.
Absolutely. I know we'll have a great discussion tonight, but last but not least, Dr. Teefy, if you want to go ahead and introduce yourself.
Good evening, everybody. My name is Patrick Teefee. I am a general obstetrician and gynecologist working primarily out of Center City and South Philadelphia at Methodist Hospital. I am from Florida, did all my training in Florida, followed my wife up to Philadelphia. We've now been here 8 years, and we've never looked back. We really fell in love with the city. There was a lack of GYN surgical care in South Philadelphia, which I've really enjoyed being a part of and helping to grow. I am also part of our educational division at the Center City campus, and the bulk of my day really is focused around the surgical and medical management of fibroids.
Okay. Well, thank you all. Again, we're in for a great discussion, so let's go ahead and dive into tonight's questions. All right. Well, Dr. Davis, I will kick it off with you for the first question here. How and why do uterine fibroids form, and what are some signs and symptoms someone has or is developing fibroids?
Okay, great. So the cause of fibroids is largely unknown, but they seem to grow in response to some of the hormones that are made by the ovary, so estrogen and progesterone. And so some of the factors that increase the risk of fibroids can include things like lifestyle, age of the first menses, number of pregnancies, genetic predisposition. But sometimes even in women who have none of these risk factors, it's still possible for fibroids to form. Some of the signs and symptoms of fibroids include heavy menstrual bleeding, pelvic pain and pressure, and sometimes difficulty with achieving fertility. And specifically as fibroids grow in size, a lot of times that can be the time where a patient may start to feel some signs or symptoms related to their fibroids.
Okay. Well, thank you so much. All right, moving along. Question number 2, Dr. Teefee. How do fibroids affect a menstrual cycle? Oh, I think you might be on mute.
Sorry, as Dr. Davis just mentioned, some of the most common signs and symptoms associated with fibroids are size related due to the presence of how big they are, but also changes in the menstrual symptom system. And a pretty broad term that we use is abnormal uterine bleeding, which really can characterize any change in what would otherwise be considered normal. Patients may report that their periods are longer than normal, they're heavier than normal, they come at an irregular frequency. Sometimes they'll report that their bleeding is happening between their periods. Sometimes patients have said that they've always been heavy, but we find out that they're admitted to the hospital with pretty severe anemia. And at that point, we kind of help them realize what the underlying cause is and help them establish treatment options to improve their bleeding.
Thank you. Dr. Gonzalez, when should someone start to be concerned about fibroids?
Well, I think women should be concerned when they start developing symptoms. So as previously discussed, we get very concerned about heavy menstrual cycles or pelvic pain and pressure. But as the uterus too gets bulky, women can start having urinary frequency or getting up frequently during the night, have back pain, leg pain, constipation. So really there's a whole host of symptoms that can be associated with fibroids. But I really do get concerned about patients when they come to my office and they say, I just can't go to work during the day, or I can't take care of my family. So I really get concerned about women who cannot carry out daily life activities. So I really encourage people to seek medical advice early on in their symptoms and to see if they can be medical managed first or may need to go on to something more involved.
Absolutely. Yeah, important advice there. Okay, moving along, Dr. Stampler, I think a big question here, can fibroids cause infertility? And if so, does removing them increase fertility?
This is probably one of the more common questions I would say most of us get in the office, but believe it or not, even the relationship between fibroids and infertility in some spaces can remain pretty controversial. I think this has to do with infertility really being a very complex concern with often several factors and maybe even several partners involved. And because fibroids have such a high likelihood in the general population, the true impact on fertility remains a little bit in question. We do know, though, that in patients that are female assigned at birth presenting with infertility, maybe 5 to 10% of those patients have uterine fibroids, and a much smaller population, maybe 2 to 4%, may be identified as the sole factor for infertility. But to kind of speak about fibroid involvement a little bit globally, I think this depends really on the size and arguably more importantly, the location of the fibroid. The fibroids can distort normal uterine anatomy, normal anatomy with the fallopian tube or the ovary, and this can prevent either the sperm and the egg from reaching the right place, potentially an embryo from implanting, so the pregnancy from implanting, or even just maintaining early pregnancy. The kind of long-lasting consensus is that the fibroids that are located inside the uterus, so what we call submucosal fibroids, are fairly detrimental to fertility. And maybe it's a little bit more controversial in terms of what we call the intramural fibroids. So those are the ones kind of in the wall of the uterus. And then many folks feel that most of the subserosal or the fibroids that are on the outside of the uterus may not impact fertility as often. Now, the ones that are in that controversial zone, those intramural or the ones in the wall of the uterus, that too is not clear and may be related on size. So you're kind of sensing a theme here that we're still not 100% sure, and depending on who you ask, different folks will recommend different things. It doesn't mean, though, that because we either don't have the evidence or the evidence that we're seeing, that doesn't exclude the possibility that these fibroids are problematic for each individual patient. And even patients that have very, very large fibroids on the outside of the uterus may require surgery, and those may be impacting fertility in some fashion. So this is why I think all of us who do this regularly really recommend that the patients seek these answers with their physician so that it can make that sort of shared decision-making approach for each individual person, because we really can't apply all of this knowledge to each patient.
Absolutely. Okay, thank you. Let's talk a little bit now about best options for removal. So Dr. Tifi, what are the best options for removing fibroids and potentially preserving fertility? If you can talk a little bit about the surgical and non-surgical options.
Yeah, so this will follow up Dr. Stampler's discussion in that I'll take it one step further in not just saying what our surgical options are to preserve fertility, but we also take into consideration how we can optimize pregnancy outcomes once they do get pregnant. And when we are presented with a patient who anticipates using their uterus to conceive and get pregnant in the future, we really start with the cavity of the uterus, which is where the baby will grow and develop. And it's really important that we normalize that architecture as good as possible. Sometimes there will be some smaller fibroids, potentially clinically significant fibroids on the outside of the uterus, and we really target our treatments towards restoring the cavity. This is really nice when we're presented with this, because we can do it in the least invasive fashion possible. We can put a small camera through the vagina, through the cervix, and restore the cavity in essentially non-invasive, no recovery time. They are fully functional the next day, and they go home the same day. It does get a little bit more complex when we have bigger fibroids in the wall, bigger fibroids on the outside of the uterus, because in order to remove those, we usually have to start talking about an abdominal surgery in some capacity. A subset of us surgeons can offer patients minimally invasive myomectomies, which is removal of the fibroids through several small incisions, whether it be laparoscopic or robotically. Many OBGYNs can do a myomectomy with a larger incision, and given the prevalence of fibroids, we still see a lot of that treatment taking place. Doing studies on pregnancy and fertility preservation is so difficult. We really have a lack of data on what the best treatment options are. We do know that in women with several large fibroids that affect certain parts of the uterus, we'll have improved outcomes with the pregnancy, but oftentimes it can come at a cost. Given the work that we do on someone's uterus, we may need them to have a C-section later on. So those are a lot of the complex shared decision-making discussions that we have that are really modified based on what our suspicion is regarding somebody's specific fibroids, how it will impact their pregnancy, and really what the patient, what their priorities and wishes are. We do have several other options that retain the ability to get pregnant, preserve fertility, preserve the uterus. There's a lot of different ways that we can phrase it. And I know that we'll get into those a little bit deeper as we progress through this conference.
Well, thank you. Definitely a lot of considerations. So appreciate you sharing that. All right, Dr. Gonzalez, we'll turn to you. Could you talk a little bit about UAE or uterine fibroid embolization?
Sure. So just to start with a little bit of the basics. So uterine fibroids require blood supply, including oxygen and nutrients, to grow. So without blood supply, the uterine fibroids will die and shrink in size. So uterine artery embolization, or UAE, or uterine fibroid embolization, is a minimally invasive, non-surgical treatment for fibroids. And what the goal is to actually starve the fibroids of their blood supply so they shrink and they die. So embolization actually means the stoppage of blood flow. The way the procedure is performed, an interventional radiologist will access an artery at the top of the right groin or in your left wrist. And under X-ray guidance, we will guide this hollow tube, or what we call a catheter, directly into the arteries, supplying the blood flow to the uterine fibroids. Once we have the catheter positioned where we want it, we inject these particles called embolization particles. And those particles will block the blood flow to the fibroids, causing them to die and shrink, alleviating symptoms in women. And following the injection of these embolization particles, we remove the catheter and we hold pressure at the skin site to allow the artery to heal. And the procedure in experienced hands typically takes about 30 minutes to 60 minutes. It doesn't require anesthesia, stitches, or large incisions. And it's a nice alternative to surgical interventions.
Okay, well, thank you. With any surgery, obviously there are risks. So Dr. Davis, what are some of the risks associated with these surgical procedures to remove fibroids?
Right. Yeah. I mean, just like you're saying, every surgical procedure, every procedure really does carry some risks with it. And so, deciding to do any procedure or intervention in general is a pretty long conversation that, just like everyone's been saying, is individualized. So, in talking about the risks of surgery, I don't want to kind of just broaden it too much, but some of the common risks associated with the surgeries that Dr. Tifi was talking about, myomectomy and hysterectomy. So myomectomy is the procedure where we remove the fibroids, and whether that's through the cavity of the uterus or from above through the abdomen. We remove the fibroids and keep the uterus in place, versus a hysterectomy, where we would remove the uterus that contain the fibroids altogether. So both of those procedures have, risks of bleeding, with a possible need of a blood transfusion, possible infection, possible development of blood clots, and injury to, structures that are around the fibroids, that are around the uterus, with possible need for other surgeries. So no surgery is done lightly and without a full discussion about all of these risks. For myomectomy, because the idea is to preserve the uterus and possibly to preserve the ability to carry a child, that leaves the potential for over time fibroids to potentially grow back. So with a myomectomy, there can be a higher risk of needing an additional surgery for fibroids in the future.
Well, thank you. All right, Dr. Sampler, we'll turn to you. What percentage of women have success getting pregnant after fibroid removal?
I know, hitting me with the tough questions again, but
Oh.
Sadly, again, not so straightforward to be able to give those exact percentages, which I know everybody just wants to have, some discrete numbers. But I think it highlights sort of a broken record here about how important it is to discuss like your particular case with a skilled physician, because a lot of this may or may not apply to you. But there is very fair evidence that myomectomy, whether that's done through a larger incision through the abdomen or smaller incisions through the abdomen with laparoscopy for those cavity distorting fibroids, will improve pregnancy rates and reduce the risk of early pregnancy loss or miscarriage. And there's also fair evidence that doing the hysteroscopic myomectomy or using that small camera through the uterus, again, to take care of those cavity distorting fibroids, also improve clinical pregnancy rates, but we really don't know what that evidence is regarding the impact of that procedure potentially on live birth rates. So getting pregnant is slightly different than having a live birth. Some older studies suggested that hysteroscopic myomectomies may increase the rate of conception over several years, depending on where the fibroid is exactly, anywhere from maybe 30 to 50% of the time. And there may even be a role for patients that are completely asymptomatic, but have cavity distorting fibroids to undergo procedures. In certain circumstances, potentially patients that are going to be undergoing artificial reproductive technology. So there are circumstances where surgery there is indicated.
Okay. Well, thank you. And I know you touched on this a little bit. Can you talk a little bit about just pregnancy with fibroids that are untreated?
Oh, sure. So about 10% of pregnant people have uterine fibroids. The good news is most are small, less than 5 centimeters. So centimeters, not inches. And many remain stable in size. About 30% or more of fibroids will increase in size in response to the hormonal changes in pregnancy, but most typically regress postpartum as well. They're usually asymptomatic, but we do see complications, and those increase with more fibroids, larger fibroids. We can see things like recurrent pregnancy loss or preterm labor. Sometimes placentas will be in different positions that are not ideal for pregnancy. We can see increasing rates of C-section due to larger fibroids potentially obstructing labor or leading to breech presentations. And fibroids can increase the risk of postpartum hemorrhage or bleeding after delivery, or something called fibroid degeneration, which is pain from outgrowing their blood supply. Fibroids may on occasion need to be removed at the time of C-section. It is not common and it is not ideal, and usually best by an experienced obstetrician. It's certainly not a primary reason for a C-section, but sometimes we have to do that at the time of delivery.
Okay, well, thank you so much for that helpful information. Dr. Gonzalez, we will turn to you. A question about untreated fibroids here. Is there a potential for them to turn cancerous?
So fortunately, cancerous, or what we refer to as malignant transformation of fibroids, is exceedingly rare. So hopefully we'll put people's minds at rest here. The incidence in the literature is actually less than 0.1%. So that means like less than 1 in 1,000 fibroids. So again, very unusual. The one thing we, and I'm sure the GYNs are very concerned about, is if a fibroid grows very quickly, especially if the woman is postmenopausal, that would raise concerns regarding malignant transformation.
Okay, thank you. And Dr. Davis, anything you'd like to add there?
I would just like to echo exactly what Dr. Gonzalez said. I think it is important in some patients where we're going to monitor their fibroids closely if there is any concern, because what can be sometimes difficult is just determining what's a completely benign or non-cancerous fibroid from what may be more concerning. And so it's not that rare where, we'll repeat some imaging, which I'm sure we're going to be talking about imaging to kind of monitor, what's going on with that fibroid and uterus over time.
Okay. Another follow-up question for you there, Dr. Davis. Are there ways to maybe naturally minimize fibroids and any ways to prevent them from getting bigger?
Yeah, that's a great question. Again, there's a lot of different factors that go into, why fibroids form, and what we do think contributes to their formation is those hormones, estrogen and progesterone. So things that can affect the levels of those hormones in a woman's body potentially can affect the growth of fibroids over time. And so some of those things that can optimize, health of the uterus includes maintaining a healthy body weight, having regular exercise, eating a healthy diet, and avoiding things like alcohol, managing your stress, and then, things that are going to decrease a woman's hormones over time. So such as going through menopause, a lot of times will stop the growth of fibroids and potentially even cause fibroids to shrink.
Okay. And are there any medications that will help shrink or get rid of fibroids?
So unfortunately, we're somewhat limited in terms of medications that actually treat or cure fibroids. We do have several medications that are used specifically for the bleeding that can be a symptom of fibroids. But really, there's one medication which is called Lupron, which in essence really lowers the body's level of hormones of estrogen to somewhat mimic menopause. And so with that medication, we can see a decrease in the size of fibroids. However, that medication for long-term use carries some significant risks to a patient's health, specifically to their bone health. And so we usually use that medication in a situation where we're kind of buying time to either get to a more definitive management option or to the point where the woman is naturally going to go through menopause on her own and stop making those hormones on her own.
Okay. And a related question that we just got from the audience as a follow-up to this, someone asked, do you recommend Lupron? And forgive me if I'm mispronouncing that, but would you recommend before surgery?
So again, it's a tricky question to just answer to everybody. It's a very individualized, I would say, decision. And there's a lot of factors that go into it. I certainly have recommended it and used it with patients, but I can't say as a blanket statement that I would recommend it in every situation.
Absolutely. Yep. Knowing that each individual, obviously has to talk to their healthcare provider. But thank you for answering that. And just for the audience, we see your live questions coming in. Thank you so much. Feel free to keep them coming in and we will get to them shortly. But for now, we'll continue with some of our questions here. Turning to you, Dr. Gonzalez, could you talk a little bit about candidacy for UAE for fibroids?
Sure. Well, of course, if a woman is having symptoms related to their fibroids, they're a candidate for the procedure. If they want to preserve their uterus and avoid a hysterectomy, or if they want to avoid surgery in general, or if a patient isn't a surgical candidate, maybe because of pre-existing medical conditions, maybe diabetes, high blood pressure, sometimes obesity can make surgeries difficult, or if somebody's had multiple prior abdominal surgeries that may make the surgery complicated. So in that regard, they could be a uterine artery embolization candidate. Absolute contraindications to uterine artery embolization, there aren't that many, but the things we worry about or if somebody has a severe allergy to X-ray contrast, similar to the contrast used for CT scans. And sometimes we can pre-medicate patients with steroids to lessen a allergic reaction to the contrast, but even sometimes patients will break through that steroid, what we call steroid prep. So we'd like to avoid using X-ray contrast in those particular patients, and UAE wouldn't be the most ideal treatment for them. The other thing is, because we use X-ray contrast, we also can be concerned about patients who have what we call renal insufficiency or kidney disease, and these patients are not quite yet on dialysis, and the X-ray contrast could affect their kidneys. And then, of course, anybody with an active pelvic infection or a pelvic malignancy is not a candidate for uterine artery embolization. And then I just, since we're talking a lot about fertility, I think it's very important, and this has been mentioned before, that, studying fertility is very difficult, but there is no conclusive data in the literature that really establishes the impact of UAE on fertility and pregnancy. So if a woman is interested in future fertility, it's very important that this decision is made in a multidisciplinary approach with the GYN, the interventional radiologist, and of course, a very well-informed patient herself. But I will say that it is very important to use a reliable source of birth control to prevent pregnancy after UAE if fertility is not desired, because I've had patients get pregnant. So it's definitely something, though, that is important just to know about.
Okay, well, thank you. All right, Dr. TV, we will turn to you along the lines of surgery. Are there any new developments or procedures for fibroids, minimally invasive options, lasers? Any new developments that you can talk to us about?
Certainly, I will get to that. I would like to touch on the Lupron question a little bit more. And I think that one of the big principles that we take into consideration preparing a patient for surgery in the treatment of their fibroids is getting their hemoglobin levels improved as much as we can to resolve any anemia. Because as we talked about, heavy bleeding, anemia is a very common consequence of having fibroids and heavy periods. So in preparation for surgery, we really want to boost those levels up as much as possible. There's several different ways to do that. Lupron is a type of medication that is excellent at shutting off one's period. And that's half of the aspect of improving the hemoglobin, by reducing the amount of blood loss that we have. And then we work on increasing the iron supplementation to help the body's natural ability to increase those levels. Another potential benefit of a medication like Lupron is to shrink the uterus in preparation for surgery, which may increase our ability to offer them a less invasive surgery than what would otherwise been offered to them. That's a medical option to do that. I work with Dr. Gonzalez very frequently. I talk to patients who want surgery, but I can't do it minimally invasive unless we get some reduction in the size of the uterus. And sometimes medicines can do it, sometimes an embolization and giving the body's 3 to 6 months to allow it to shrink in preparation for surgery is an excellent alternative. Moving to new developments, I am thrilled that Jefferson has supported our ability to introduce Sonata, which is a form of a transcervical fibroid ablation. We've completed a successful 10-patient trial. We are finalizing the details to allow this to be a permanent option for patients at Jefferson. Essentially, it allows a targeted transcervical, essentially transvaginal treatment of fibroids by introducing radiofrequency ablation towards it. There are some similarities in how the fibroids respond to that treatment to what Dr. Gonzalez offers, but there's not a lot of overlap in terms of who would be better for one or the other based on fibroid size, locations, and infertility goals. So A very much different procedure, but certainly an option that we discuss frequently with the patients.
Okay. Well, thank you for going into that. We appreciate it. Dr. Sampler, we will turn to you for another question before we take some live questions from the audience. Is it possible for fibroids to return if they are removed surgically? And if so, is it serious if they return?
So this is a great question because I find that many patients and physicians maybe that are unfamiliar with fibroids and management might be surprised to hear that recurrence is not uncommon at all. It can happen more with procedure type and size of the fibroid, but doesn't necessarily mean if there's a recurrence that you have to have a second type of procedure or intervention. Because as we know, fibroids can also be asymptomatic, so no symptoms at all. In terms of it being serious, it depends on a lot of factors. Some of them might be age or how quickly fibroids come back or where or the size. But more often than not, these are not cancerous, but there could always be findings that might make us think that there may be more of a problem than we had initially thought, but it's not uncommon to see recurrence.
Okay, interesting. And do you have any odds around the odds of fibroids returning after treatment? Is any numbers that you can share with us potentially?
Sure, it can be a little tough, as we know, to sort of apply those widely. I think when we look at studies, we look at patient population. So if the patients in the study are not the same age as you or race as you or fertility status, the same data may not apply. And so that's why it can be a little bit challenging to kind of generally give a lot of information and why each person has that individualized plan. But the few things that we know is that recurrence may be more common with older age or larger preoperative number of fibroids or greater uterine size. Things that might actually decrease recurrence may be birth control pills or injectable medications like Depo-Provera. We also have noticed that surgical technique in terms of removal may make a difference. So patients may actually have what's called a staged procedure. Hysteroscopically, you may have a very large cavity distorting fibroid that we have planned to do on 2 separate days. And so having a second procedure is not uncommon in those scenarios. We also have seen from a variety of sources that there may be recurrence rates in terms of patients requiring more intervention at about 12%. That doesn't mean that every person needs to have surgery, but we're looking around that number. And then when we look out in terms of 1 year to maybe 5 years, there can be recorded recurrence rates anywhere from maybe 10 to 15% at the 1 year mark, and maybe as high as 40 to 60% at the 5 year mark. So we're getting kind of into the high numbers. We have in some studies seen a trend potentially for some higher recurrence rates in patients that have undergone potentially minimally invasive surgeries. It's not clear in other studies, but when we look at the overall benefit of minimally invasive gynecologic surgery and we weigh that against the pros and cons of abdominal approach, a large incision, we find that minimally invasive surgery may have an advantage there, even if there's a small difference in recurrence rate.
Very interesting. Well, thank you. All right. Well, with that, I think let's go ahead and turn to some of the live questions. I know the audience has been submitting them, and thank you so much for your engaging questions here. So we'll start with the first question, and whoever wants to answer, feel free to chime in. But this person is wondering, can you have UFE twice?
Yes, so you definitely can have UFE twice. I think just to go back to what we were talking about, recurrence, I think with uterine artery embolization and uterine fibroid embolization, we've learned a lot over the last couple of decades about the embolization particles that we use to stop the blood flow to the fibroids, and they are not all created equally. So I think in the beginning, when we first started performing this procedure, everybody wanted to create an embolization particle. All the marketing, everybody wanted to learn how to, or sell their product. And then we discovered that, we weren't causing 100% infarction or kill of the fibroids. So fibroids came back and patients needed, additional therapy. So you can go ahead and definitely repeat the treatment And sometimes after you do uterine artery embolization, the uterine arteries, which are what the main blood supply to the uterus, may no longer be supplying the fibroids, but what we see is parasitization of other arteries, such as the ovarian arteries supplying the fibroids. So yes, you can have the procedure done twice, and it usually doesn't increase any risk of complications.
Okay, thank you. All right, next question we have here. How small is too small to do anything about fibroids? And whoever wants to jump in here, feel free.
I had to repeat the question in my mind a couple of times. So, I think really the question is this causing, a problem in terms of your quality of life? And, are you kind of at that point where, yeah, you are running to the bathroom, every 20 minutes and, you feel kind of like you're having some symptoms of feeling pregnant, some pressure, and, it's enough to really disrupt, your day-to-day life, then that is the correct size to do something about them. Same goes for bleeding. I mean, sometimes the fibroids that are, inside the cavity of the uterus causing bleeding are not, terribly large. And so, but that can very much impact your health and your quality of life. And so really, if you're having symptoms, then, that's the time to start your discussion with your GYN, or seek someone who will have that discussion with you.
Okay, thank you.
I was just gonna add that, totally agree with those statements. The one thing that we do prior to uterine artery embolization is always get an MRI of the pelvis. A lot of women come to us with ultrasounds, which are a great way of diagnosing if a patient has fibroids or not. But we usually get an MRI to see if there's any other causes of bleeding as well, because the MRI is definitely the gold standard for, evaluating the female anatomy. So sometimes we could see some other benign conditions that can cause bleeding that can be in conjunction with fibroids. So it's just something for the attendants to know.
Yes, thank you. Okay, next question here. Is there any correlation between polycystic ovarian syndrome and fibroids? This person is curious to know. Throwing some tough questions at you.
I'll just say, I just because I answered these questions earlier, but really, the hormones that make fibroids grow are estrogen and progesterone. And so with polycystic ovarian syndrome, you have higher levels of estrogen, and sometimes that starts very early on in a woman's life. And so that long-term exposure to estrogen theoretically could, cause fibroids or cause fibroids to grow over time. I don't know in studies how substantiated that is, just because in studies we find fibroids in so many women. So I don't know that it has kind of fleshed out for that particular subset of women who also have PCOS, that the rate is higher in them. But it does make sense to me that more estrogen with PCOS would be linked to more fibroids.
Okay. Thank you. All right, next question here. What are some things that someone can do to enhance healing after a myomectomy and to regulate hormones so that the fibroids are less likely to come back? And happy to repeat the question as well.
I'll touch upon the recurrence risk. So I'm not, and Dr. Davis and Dr. Teefy can comment on this as well. I typically don't prescribe hormonal medication in these circumstances to help prevent recurrence risk. If patients are already taking it, it may decrease that risk, but I'm not using anything routinely in my practice to say take birth control pills or Depo-Provera to prevent that from coming back. In terms of enhancing after hysteroscopic myomectomy, I think probably similar post-operative instructions would ensue. So there's nothing that I give specifically for that particular procedure, aside from just treating your body well for the few days after surgery and taking appropriate rest to heal after a procedure. But I'll let them weigh in if there's something else I should be doing differently that I need to update my practice.
All right.
I
I think, sorry, jumping in. I think that there's, after surgery, we historically would tell patients that you need 6-week recovery time, and that's gone by the wayside. With a lot of our minimally invasive options, we have patients back to work much sooner. We have them returning to their normal life much sooner. Myomectomy patients, historically, when they were done open, patients would be in the hospital for 2 to 3 days. And it would be 6, sometimes 8 weeks off from work. Now, when we offer laparoscopic or robotic myomectomies, patients go home the same day. I generally tell my patients, depending on the physical demands of your job, a lot of patients are back at work within 2 to 3 weeks. If they work remotely, which is so common these days, they can often be back to work in 7 to 10 days, maybe less, depending on the relationship with their employer and what their goals are. So this is certainly, I tell patients that when they are recovering from these minimally invasive surgeries, this is not bed rest. This is, I want you out of bed. I want you moving around. I want you, yes, go to the store with somebody, driving you the weekend after surgery. Get out of the house, move around, listen to your body, and don't do anything that you would consider overly aggressive. But we really want patients up, moving around, restoring their normal quality of life and activity levels.
One thing I'll kind of add to that too is, I think this is one of those instances where it's just important to listen to your body. And part of the advantage about, seeking out care and advice from a GYN early on in the process, when you're starting to feel symptoms, is that the recovery is so much easier with the minimally invasive approaches. And so, fibroids are just tricky because some people have fibroids that grow very quickly, and some people, it takes a long time for their fibroids to grow. But I think knowing for yourself that these are there and being able to make decisions earlier on in the process ultimately allows you to heal and recover from a surgery that may not have to be so involved if you were to wait till the symptoms are really terrible and your uterus is really large.
Absolutely. Well, thank you all for weighing in there. Great discussion and great points. Okay, we have a few more questions to get to before we close out the evening. So a question here, and Dr. Sampler, I know you touched on this a little bit earlier, but does birth control help with managing the symptoms of the fibroids? And also somewhat related on this note, if you are on birth control and have a small fibroid, are there any suspected negative side effects?
I'm sorry, can you repeat the first part again?
Yeah, of course. So does birth control help with managing symptoms of the fibroid? Yeah.
So it depends. It depends on where the fibroid is located and what we're using the birth control pill for. The birth control pill is probably not going to give you any significant volume reduction, and certainly not going to do that for large intramural or those fibroids on the outside of the uterus, and probably won't affect bleeding for those particular fibroids. But as Dr. TV touched on before, some of those medications and procedures related to fibroids that are cavity distorting, the birth control pills may help with that in those scenarios. And then in terms of, was the second question side effects or?
Yes. The second question, oh, now I'm like losing it. Here we go. Yep. Are there any suspected negative side effects if you're currently on birth control and have a small fibroid?
That is a very loaded question that in terms of birth control pills and side effects may not be specifically related to fibroids, but again, we wouldn't anticipate a large growth in fibroids just from birth control pills.
Okay, well, thank you. All right, moving along, are there any options for people who cannot have an MRI because they have metal pins or rods in their bodies?
So ultrasound, obviously, is a very good diagnostic tool for fibroids. So you don't have to have an MRI to diagnose fibroids. Sometimes what we like to see is vascularity of the fibroids, and we have some newer techniques called contrast enhanced ultrasound, which is very, very neat. It actually is able to show tinier vessels, the microvasculature of the fibroids, even better than color Doppler, which is a way of looking at vascularity with ultrasound. So I've had women who could not get an MRI, but I wanted to make sure that the fibroids were very vascular, and we would inject this contrast agent, which is very, very simple, and it's extremely safe. It's FDA approved, but it's really a nice new technique for looking at vascularity of fibroids, and very sensitive.
Okay, thank you. All right, Dr. Tifi, question for you. The ablation procedure that you mentioned previously, this person is curious when that will be available.
So, like most things these days, there's a pretty regimented process that new technology needs to go through before it's widely adopted and, purchased by any institution. So my goal, honestly, is that I hope that we're fully ready to go, taking all consults and offering it come summertime.
Exciting. All right. And I think for our last question here of the night, and then we will close it out with one final question that I have, but Dr. Gonzalez, will turn to you. What is the average time for fibroid shrinkage with UAE? And does the UAE procedure need to be repeated based on the size of the fibroid?
So most of the literature looked at 3 months following uterine artery embolization to look at the shrinkage of size of the fibroid. So there's an average of about 50% shrinkage of fibroids at a 3-month period. However, we know that the fibroids can continue to shrink even up to 12 months. So there are some smaller studies that are out there that looked at 9 to 12 months that even showed fibroids shrinking as much as 75%. So it's very important, though, that the shrinkage for bleeding, issues such as the heavy menstrual cycle, as long as the fibroids typically have no blood flow, the women's symptoms are going to get better. So greater than 90% of patients will have improvement in their menstrual cycles. The bulk-related symptoms, which we talk about, their urinary frequency, constipation, bloating, back pain, leg pain, that kind of thing. Sometimes, even if the fibroid shrinks about 50%, it might not be enough to completely alleviate a woman's symptoms. But if the fibroid's already completely necrotic or dead, there's no reason to repeat the uterine artery embolization. So that's why we'll get MRIs after the procedure just to see the vascularity of the fibroids. Sometimes you can miss fibroids and they're not treated, and you can go in and repeat the procedure. But typically, if they're already necrotic, there's no reason to go back in.
Okay. All right. Well, thank you all. Those are our live questions for the night. And I know I have one final question for myself before we close it out, but a wonderful discussion. But for the final question this evening, I would love to know, what are your goals for everyone listening in on this webinar? What would you like our viewers to take away from tonight? And Dr. Davis, we'll go ahead and start with you.
Well, first, I just want to thank everyone for attending, and thank everyone who's hosting this for inviting me to be a part of it. It's been a really great webinar. I I think what I'd like everyone to take from this is just that fibroids are a very common problem. And there are a lot of different options in terms of management. So please just don't hesitate to, book an appointment, see your OBGYN if you are experiencing any signs or symptoms. If you're not satisfied, with the options available, it's perfectly fine to, get a second opinion and seek out other options. And, just we are here, to help you.
Absolutely. Well, thank you so much. All right, Dr. Gonzalez, any closing remarks for tonight?
Sure, and thank you so much for having me here as well, and thank you for everybody who attended. I think the thing that I would like to emphasize, and I think we said this a couple of times, is that women are very notorious for taking care of others before themselves. So it's very important if these symptoms develop not to wait too long until it becomes a very large problem. So I think that's one of the take-home points. The other thing is there are lots of treatment options, whether it's uterine artery embolization, surgery. It is really going to be individualized, and it's nice to have a multidisciplinary approach. One size doesn't, fit all. So it's just kind of important just to kind of be educated about your potential options out there and speak to fibroid specialists early on in the disease process.
Absolutely. Well, thank you. All right. And Dr. Sampler, any closing remarks from you?
Yes, thank you. So something I wanted to just touch a little bit more on before we leave is the very large racial disparity that we have with fibroids, with studies showing a threefold increase in the risk of fibroids among Black women compared to white women when we control for various risk factors. Black women have developing uterine fibroids at a younger age. They present with larger uteri at the time of diagnosis and suffer from more anemia related to fibroids compared to white women, and more importantly, are less likely to be offered minimally invasive surgery. So I really want to make it very clear that it is so important to have those frank conversations with your physicians about all of your options. Maybe inquire as to what your candidacy for minimally invasive surgery is, and seek a second opinion if needed. We're here for that. We encourage that for our own patients. When we see patients for consultation, it's a real opportunity to review your history and imaging and goals to really craft that personalized plan for each patient. We might not have the answers always, as you can identify tonight, but we'll always be very transparent with that and work with you to achieve your goals with our available options and abilities. So thank you so much for your time. I know it's very valuable, and we look forward to potentially seeing you in our offices.
Absolutely. Well, thank you for raising that point. And yes, the importance of self-advocacy. So thank you. Okay. And again, last but not least, Dr. Teefee, any closing remarks from you?
So I think now more than ever, it can be so difficult navigating healthcare and getting an appointment. And sometimes there's a level of desperation that these patients have, and they'll really see anybody that has space or who can accommodate an office session. Sometimes it's difficult to get in initially with a fibroid specialist. But I think I would like to commend all the attendees for being here. I think being informed, learning about what their options are. I'm sure that this is not their only platform. I'm sure that they, most of the attendees have done a lot of research. When you come, we represent a much larger group of physicians, the four of us, and working at a big healthcare system like Jefferson Health, I think that we have a pretty good system in place that, just get your foot in the door, and most providers will help, determine what a patient's needs are and get them routed to the right provider based on what they want. For many of the panelists here today, there's really no limitations on who can be offered minimally invasive surgery. So, patient advocacy is important, and sometimes you just have to ask the right questions and ask them enough, and we'll help you get to where you need to go.
Well, thank you all so much, Dr. Davis, Gonzalez, Stampler, and Dr. Tifi for your time this evening. A lot of terrific information was shared. And thank you all for attending and submitting your questions. Well, we will be posting an event survey so you can let us know your thoughts. Any other specialties you would like to hear from, your feedback will bring more virtual events like this to you, the patients. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please fill out the last question in the event survey. And be sure to visit jeffersonhealth.org to make an appointment, stay up to date on upcoming events and webinars, just like this one and more. Please also visit jeffersonhealth.org/livingwell for more health content, patient stories, research, innovation, and more. You can also visit the Jefferson Health YouTube page to view more wellness webinar series events. We have various topics ranging from back pain to robotic surgery to previous before the bump webinars. A recording of this event will also be sent to you so you can rewatch at your convenience. And if there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a wonderful evening.